Welcome to this video on diabetes and pregnancy. We'll be covering high-yield obstetrics content for nursing exam prep. What is the gold standard screening test for gestational diabetes mellitus, GDM? Options include fasting blood glucose, 75 grams oral glucose tolerance test, OGTT, random blood sugar, and urine sugar analysis. The correct answer is B. The 75 grams OGTT is the recommended diagnostic test by IADPSG and ADA to diagnose GDM, as it provides a standardized assessment of glucose tolerance. Which congenital anomaly is most commonly associated with pregestational diabetes? Choices are neural tube defects, cardiac anomalies, renal agenesis, and limb reduction defects. The answer is B. Cardiac anomalies, specifically VSD and transposition of the great vessels, and caudal regression syndrome are the most common anomalies associated with pregestational diabetes. Which hormone is responsible for the increase in insulin resistance during pregnancy? The options are progesterone, human placental lactogen, HPL, estrogen, and relaxin. The correct option is B. Human placental lactogen, HPL, produced by the placenta, is the primary insulin antagonist that causes physiological insulin resistance in pregnancy. Macrosomia in an infant of a diabetic mother, IDM, is defined as a birth weight of A, greater than 3,500 grams, B, greater than 4,000 grams, C, greater than 4,500 grams, or D, greater than 5,000 grams. The answer is B. Macrosomia in an IDM is generally defined as a birth weight greater than 4,000 grams, resulting from fetal hyperinsulinemia secondary to maternal hyperglycemia. What is the immediate complication a neonate is at risk for after delivery from a diabetic mother? Is it hyperglycemia, hypoglycemia, hypercalcemia, or hypokalemia? The answer is B. The neonate has fetal hyperinsulinemia due to constant maternal glucose exposure. Once the cord is clamped, the maternal glucose source is cut off, leading to rapid hypoglycemia. Which of the following is a target fasting blood glucose level in a pregnant woman with GDM? Is it less than 95 milligrams per deciliter, 110 milligrams per deciliter, 130 milligrams per deciliter, or 150 milligrams per deciliter? The correct answer is A. ADA and ACOG recommendations for GDM management target a fasting plasma glucose level of less than 95 milligrams per deciliter to ensure adequate fetal development. Which of the following is not a complication of pregestational diabetes in pregnancy? The choices are polyhydramnios, preeclampsia, intrauterine growth restriction, IUGR, and preterm labor. The answer is C. IUGR is less characteristic than the others unless there is severe vasculopathy. Pregestational diabetes can cause vascular damage leading to IUGR, but it is typically associated with macrosomia. What is the most effective lifestyle intervention for GDM? Options are complete bed rest, carbohydrate-controlled diet and regular exercise, high-protein zero-carb diet, or increased caloric intake. Answer B is correct. Medical nutrition therapy combined with moderate exercise is the first-line treatment for GDM to stabilize blood glucose levels. Why are diabetic mothers at risk for polyhydramnios? Is it due to fetal polyuria, decreased fetal swallowing, maternal dehydration, or excessive placental size? The correct answer is A. Fetal hyperglycemia leads to osmotic diuresis, which increases fetal urine production and results in polyhydramnios. The drug of choice for management of GDM if diet fails is metformin, glyburide, insulin, or sitagliptin. Answer C is correct. Insulin is the preferred medication for GDM management if lifestyle interventions fail, as it does not cross the placenta. What is the purpose of screening for GDM at 24 to 28 weeks? The options are to identify fetal anomalies, because this is when placental insulin resistance peaks, to prevent early miscarriage, or to assess maternal weight gain. The answer is B. Screening occurs at this time because placental hormone production peaks during the second and third trimesters, causing maximum insulin resistance. Which of the following is a symptom of diabetic ketoacidosis, DKA, in pregnancy? Options are hypertension, Kussmaul respirations, bradycardia, or peripheral edema. The correct answer is B. Kussmaul respirations are deep, labored breathing patterns that are a compensatory mechanism for metabolic acidosis in DKA. What is the ideal time for delivery in a well-controlled GDM pregnancy? At 36 weeks, at 39 to 40 weeks, before 34 weeks, or induce immediately at diagnosis? Answer B is correct. For well-controlled GDM without complications, delivery is recommended at 39 to 40 weeks, which is considered full term. Which of the following is a maternal risk factor for GDM? Low BMI, age less than 18 years, history of GDM in previous pregnancy, or regular exercise. The answer is C. A history of GDM in a previous pregnancy significantly increases the risk of developing it again in subsequent pregnancies. Respiratory distress syndrome, RDS, in an infant of a diabetic mother, IDM, is due to fetal hypoxia, delayed surfactant production due to high insulin, prematurity only, or meconium aspiration. The correct answer is B. High fetal insulin levels inhibit the production of surfactant, which is essential for proper lung expansion, leading to RDS. Insulin requirements usually decrease in which trimester of pregnancy? Is it the first, second, third, or they remain constant? Answer: B. Insulin requirements decrease in the first trimester and then increase progressively through the second and third trimesters as placental hormones increase insulin resistance. What is the target HbA1c for a pregestational diabetic patient planning pregnancy? Choices are less than 6.5%, 8.0%, 10%, or greater than 9%. The correct answer is A. A target HbA1c of less than 6.5% before conception and during pregnancy minimizes the risk of congenital anomalies and other adverse outcomes. Which diagnostic finding in OGTT confirms GDM? Any value greater than 140 milligrams per deciliter, 2 or more abnormal values in 3-hour OGTT, random sugar greater than 200 milligrams per deciliter, or a single abnormal fasting value? Answer B is correct. GDM is typically confirmed by 2 or more abnormal values during the 3-hour, 100 grams OGTT, according to the Carpenter-Kooston criteria. What is the long-term risk for a mother who had GDM? Ovarian cancer, type 2 diabetes mellitus, hypertension, or osteoporosis? The correct answer is B. Women with GDM have a significantly increased risk of developing type 2 diabetes mellitus later in life and should be screened regularly. What is shoulder dystocia? Is it a breech birth complication, failure of shoulders to deliver after the head, cord wrapped around the neck, or failure of the head to engage? Answer B is correct. Shoulder dystocia is an obstetrical emergency where the baby's shoulder gets stuck behind the mother's pubic bone after the head has been delivered. Which test monitors fetal well-being in GDM? Non-stress test, NST, biophysical profile, BPP, both A and B, or none? The correct answer is C. Both the non-stress test and the biophysical profile are used for antepartum surveillance to monitor fetal well-being in pregnancies complicated by GDM. Why is insulin dosage often decreased immediately postpartum? Placental hormones leave the body, the patient is eating less, to prevent infection or insulin production increases. Answer A is correct. The sudden removal of the placenta and its insulin antagonistic hormones causes a rapid decrease in insulin requirements, often necessitating a lower dosage.